Hello, my name is Kevin Epps. I'm an antimicrobial stewardship pharmacist in the Jacksonville, Florida area. I want to thank you for joining me for microbial clinical quandaries in cystic fibrosis. This particular presentation was developed by myself and Dr. Jeff Zobel. We both are clinical support liaisons for MVW. When you start to look at the prevalence of respiratory microorganisms by age, you can see by far that Staph aureus is the most common organism isolated in patients with CF when looking at the most recent CF registry data. As these patients start to get older, these patients start to develop things like Pseudomonas aeruginosa and MRSA. This slide provides you with information of antibiotics that you can use for patients if you're treating MSSA outpatient. Antibiotics like amoxicillin clavulanate, trimethoprim sulfamethoxazole, and cephalexin, to name a few. If your patient is treated inpatient, there are no standard guidelines on what to treat with. Usually we're using agents like nafcillin or oxacillin or cefazolin. The doses below are in a chart to give you the doses for nafcillin and cefazolin. Sometimes when patients have MSSA and Pseudomonas, you can use broader agents like cefepime, piperacillin tazobactam, or meropenem that will cover MSSA as well as Pseudomonas. MRSA starts to increase around the age of 6 to 10, reaches its apex around the age of 18 to 24, and then starts to decline. MRSA in cystic fibrosis, why does it matter? It matters because when patients with cystic fibrosis are colonized with MRSA, it can affect the FEV1. The FEV1 can decline more rapidly, and we're concerned about these patients getting back to their baseline FEV1 after that exacerbation. Persistent MRSA infections are associated with increased antibiotic use, increased hospitalizations, as well as longer hospital stays, and MRSA in CF can be an independent risk factor for mortality. This brings us to our first case, TJ. TJ is a 7-year-old male with cystic fibrosis. He is chronically colonized with Pseudomonas aeruginosa. He has had 2 hospitalizations in the last year for exacerbations. Review of sputum shows an initial isolation of MRSA for the first time. He has an allergy to sulfa, which is anaphylaxis. Home meds include elexacaftor, MVW vitamin, Creon, albuterol, cyproheptadine, lansoprazole, and Dornase alpha. This brings us to our first clinical quandary. The clinic physician asks about treating MRSA eradication. What do you do? What do you recommend in this particular case? So let's talk about MRSA eradication, the STAR2 study. This particular study was done to determine if an early eradication protocol is effective for the eradication of MRSA. This particular study was done in the US at 14 cystic fibrosis accredited centers with 24 patients in the prescription group and 21 patients in the observation group. And what they wanted to find out is if they did this eradication protocol, would there be a difference in the proportion of MRSA negative subjects on day 28 between the 2 arms? These particular patients were treated with sulfamethoxazole trimethoprim plus rifampin or minocycline plus rifampin. They received nasal, body, and also oral decontamination, as well as enhanced household cleaning. When we look at day 28, which was 14 days after the patients finished receiving the eradication protocol, when you look at the treatment group, you can see that there was a statistically significant difference in MRSA negative cultures at day 28, which was 14 days after they finished receiving treatment. However, keep in mind there were 26% of patients who were in the observation group who did not culture out MRSA on day 28. This particular study demonstrated microbiological efficacy, But what we found out 6 months later, there was no difference in those patients who either received this eradication protocol or the observation arm, with 57% of patients being MRSA negative at 6 months in the active arm and 53% of patients being MRSA negative in the control arm. In the STAR2 study, rifampin was part of all of the eradication protocols. And as you can see, rifampin can affect all of our modulators. So if we want to attempt a MRSA eradication protocol, that's something that we have to take in mind. So do we just do the protocol and just not use rifampin? Do we use the same protocol but just substitute rifampin out for another anti-MRSA agent? So these are some discussions that we can have with the patient as we decide what's best for our patients. This brings us to clinical quandary number 2. The clinic physician decides to start vancomycin for MRSA and asks you about vancomycin monitoring. Should we monitor vancomycin by trough or by AUC in this case? What should we do? This is very important for us to think about because there are new guidelines that do not recommend trough monitoring anymore. They recommend monitoring vancomycin by AUC with a level of 400 to 600, but there are no cystic fibrosis guidelines on vancomycin monitoring. This particular study that recently was published by Mitchell and colleagues does a retrospective review of patients receiving vancomycin monitored by trough or by AUC. This particular study had 36 adult patients and 26 pediatric patients who were admitted to the University of Kentucky Healthcare between October 1st, 2015 and January 31st of 2021. These patients had to receive at least 5 days of IV vancomycin to be included. And what they wanted to compare in this particular study is if they received monitoring by trough or AUC, they wanted to compare the occurrence of AKI. They wanted to look at the rate of return to baseline lung function and also the time to the next exacerbation. So let's look at the incidence of acute kidney injury. Acute kidney injury was defined as a serum creatinine increase of 150% or greater, or a serum creatinine increase of 0.3 milligrams per deciliter or greater. There was no statistically significant difference found in AKI if these patients were monitored by trough or AUC when looking at the adult patients and pediatric patients together. When we look just at the adult patients, there was no statistically significant difference in AKI, whether they were monitored by trough or by AUC. And the same thing with pediatric patients. One thing I will bring your attention to, though, is that there was one grade 2 AKI and one grade 3 AKI in those patients monitored by trough. But keep in mind, these patients that were monitored by trough, these adult patients were more likely to be on more nephrotoxic agents in combination with vancomycin. When looking at return to baseline, there was a statistically significant difference if these patients were monitored by trough or AUC, with more patients returning to baseline if they were monitored by AUC. When we look at just the adult patients, there was a statistically significant difference in patients who were able to return to their baseline FEV1, 86% if they were monitored by AUC, and about 60% if they were monitored by trough. This was found to be statistically significant. Keep in mind, these patients monitored by AUC, there were more patients who were on concomitant CFT modulator therapy. And when we look just specifically at our pediatric patients, there was not a statistically significant difference in return to baseline FEV1 if these patients were pediatric patients. Return to baseline was if these patients were able to return within 10% of their baseline FEV1 at discharge, and their baseline FEV1 was their highest FEV1 in the previous 6 months. Time to next exacerbation in days was also examined. When you look at the adults, whether they were monitored by trough or AUC, there was no statistically significant difference, as well as when you looked at the pediatric patients monitored by trough or by AUC, no statistically significant difference in the time to next exacerbation in days. There was information missing on 9 adults and 11 pediatric patients as it relates to the time to the next exacerbation. This particular article suggests that AUC monitoring has minimized toxicity without negatively affecting efficacy in adults, and that AUC monitoring should be considered in adult CF patients given less severe AKI and potential increase in efficacy. This publication shows the evidence-based dosing of anti-MRSA agents that can be used for patients that have MRSA with cystic fibrosis. Next, we're going to talk about Pseudomonas aeruginosa. You can see Pseudomonas starts to increase around the age of 18, and then around the age of 35, it starts to reach its apex and just kind of levels off at that particular point. We know that cystic fibrosis patients have this vicious cycle of obstruction, inflammation, and infection. So we're going to talk about IV and oral antimicrobial agents that can be used when these patients have exacerbations. For Pseudomonas aeruginosa, usually 2 agents are used, a beta-lactam plus an aminoglycoside, a beta-lactam plus a quinolone, or a quinolone plus an aminoglycoside. These are all our anti-pseudomonal beta-lactams. We've gotten a couple gifts here lately in the last couple years with new anti-pseudomonal beta-lactams that we can use for our CF patients. Very important, though, that we dose them correctly so we don't have resistance developed to these agents. Our beta-lactams are going to work by inhibiting cell wall synthesis. These agents are bactericidal, so they kill the bacteria. We try to optimize our beta-lactams by increasing more time above the MIC. So sometimes we'll do things like continuous infusions or extended infusions to optimize our beta-lactam therapy. This brings us to our clinical quandary 3. The clinic physician decides to start ceftazidime and tobramycin for Pseudomonas aeruginosa and ask how we should administer the ceftazidime as either a short infusion over 30 minutes or as a continuous infusion. So what do you recommend? This brings us to the Uber study. This was a prospective randomized crossover study that compared continuous versus intermittent infusions of ceftazidime for the treatment of exacerbations of cystic fibrosis. It was conducted in September 2001 to May 2003 in France and included 70 CF patients with 8 adult CF centers and 7 pediatric centers. The primary outcome was a change in FEV1 from the beginning to the end of the IV course of antibiotics. They compared the change in FEV1 from the start of the treatment to the end of treatment between the 2 groups. They looked at the FEV1 at the beginning of the short infusion ceftazidime group and again at the end and looked at the mean change. They also looked at the FEV1 at the beginning of the continuous infusion ceftazidime group and also what the FEV1 was at the end of the treatment. And then they compared the mean change in FEV1 after the short infusion ceftaz to the mean change in FEV1 at the end of the continuous ceftaz group, and they were able to show that there was a statistically significant difference in mean change in FEV1 when they compared the FEV1 from the end of the short infusion ceftazidime group to the end of the FEV1 at the end of the continuous infusion ceftazidime group. They also looked at the change in FEV1 from the start of the treatment according to the susceptibility of the Pseudomonas to ceftazidime, whether it be susceptible, intermediate, or resistant. And what they were able to show is that in the resistant strains, at the end of the treatment, the patients in the continuous infusion group had a statistically significant difference in change in mean FEV1. They also looked at the time until the next exacerbation in months, and they were also able to show that in the intention to treat group and in the per protocol group, there was a statistically significant difference until the next exacerbation when they compared that to the short infusion group. Ways from this particular study was that continuous infusion ceftaz was safe and effective, and that patients in the continuous infusion group had a longer time into the next exacerbation, and these patients that harbored a resistant strain of Pseudomonas had a higher change in FEV1 at the end of therapy. The international consensus recommendations for the use of prolonged infusion beta-lactams is out. It is endorsed by the Cystic Fibrosis Foundation. I encourage you to take a look at this publication as it does touch on issues related to cystic fibrosis patients as it relates to prolonged or continuous infusions. This brings us to our anti-pseudomonal aminoglycosides. Gentamicin currently is not recommended by CLSI to treat Pseudomonas. Amikacin is only recommended to be used for urinary isolates. Tobramycin is still being recommended to treat Pseudomonas. However, the breakpoint has been lowered to less than 1 to be susceptible. Aminoglycosides are going to work by binding to the 30S subunit of the 50S ribosome and inhibit protein synthesis. We try to optimize our anti-pseudomonal aminoglycosides by increasing our Cmax to MIC ratio. So usually that means giving higher doses once a day. Fluoroquinolones and cholistomethate. Fluoroquinolones are going to work by binding to DNA gyrase. By binding to DNA gyrase, it inhibits the DNA from being able to replicate, causing cell death. And polymyxins are going to work by acting as a detergent and kind of wiping that cell membrane away. Very important that polymyxins are usually used in combination, not as monotherapy for Pseudomonas aeruginosa. And for these particular agents to optimize therapy, it's all about exposure. So we're usually dosing these more frequently. So for instance, using things like ciprofloxacin, 400 milligrams IBQ8 as a target dose for an adult CF patient that has Pseudomonas aeruginosa, and adjusting renally if we need to. Now we're going to talk about some inhaled antibiotics, tobramycin, aztreonam, and colistin. And these are agents that we try to use to prolong that time into the next exacerbation. Inhaled tobramycin works by inhibiting the bacteria's ability to make proteins. About 57% of patients that are greater than the age of 6 with Pseudomonas aeruginosa are prescribed inhaled tobramycin, and about 17 to 18% less than 5 that have Pseudomonas are prescribed inhaled tobramycin. It is dosed at 300 milligrams twice daily for 28 days on and 28 days off, or 112 milligrams twice a day, 28 days on and 28 days off. Benefits of inhaled tobramycin are improved lung function, reduction in the density of Pseudomonas aeruginosa, which can potentially decrease hospital admissions. Adverse effects are coughs, dyspnea, and increased sputum, just to name a few. Inhaled aztreonam is going to work by inhibiting the ability of the bacteria to maintain the cell wall. Inhaled aztreonam is used by 35% of patients that are greater than the age of 6 with Pseudomonas aeruginosa, and about 1 to 3% of patients that are less than 5 years of age that have Pseudomonas aeruginosa. Inhaled aztreonam is FDA approved for CF patients greater than the age of 7 with Pseudomonas with an FEV1 of greater than 25 and less than 75. It's dosed at 75 milligrams 3 times a day for 28 days on and then 28 days off. Of inhaled aztreonam are an improvement in lung function as well as reduced Pseudomonas aeruginosa, and also reduce hospitalization, with some adverse effects being cough, wheezing, and chest discomfort, just to name a few. Cholistomethate sodium is currently not FDA approved as an inhaled medication. It has insufficient evidence currently to recommend routinely in patients greater than the age of 6. Roughly about 6% of patients that are greater than the age of 6 are using it. and use has declined in recent years. This brings us to our clinical quandary 4. The clinic physician asks how long we should treat for Pseudomonas aeruginosa. What do you recommend in this case? Individuals treated with IV antibiotics for a pulmonary exacerbation have decreased since 2019. Top 2 study, we do find that patients that were treated for 10 days, it was not inferior to patients treated for 14 days, and 14 days was not inferior to patients treated for 21 days in patients who had an early response. This is a publication by Zobel and colleagues. This shows us the evidence-based dosing for beta-lactams, aminoglycosides, and also fluoroquinolones. Very important for us to make sure that we optimize our doses when our patients come in for acute exacerbations so that we're able to potentially get our patients back to their baseline FEV1. Next, we're going to talk about Haemophilus influenza. Haemophilus influenza is a top 3 microorganism isolated in pediatric CF patients. Clinicians would regard Haemophilus influenza as a pathogen if it was isolated. There are currently no cystic fibrosis guidelines specifically for Haemophilus influenza. You can use agents like amoxicillin clavulanate or cefdinir to treat these patients outpatient if they have Haemophilus influenza. And if your patient has to be admitted, all anti-pseudomonal beta-lactams have some activity against Haemophilus influenza. Next, we're going to talk about Stenotrophomonas multifida. Resistance is a major issue when you talk about Stenotrophomonas in cystic fibrosis. There are currently no guidelines on how to treat. I now want to bring back our patient TJ. Remember, TJ was our 7-year-old male with cystic fibrosis who's chronically colonized with Pseudomonas aeruginosa, who has now had MRSA isolated for the first time. This now brings us to our clinical quandary number 5. Microbiology now pages you to tell you that TJ now also has Stenotrophomonas multifida that was just isolated in the sputum. Remember, TJ has an allergy to sulfa, with the reaction being anaphylaxis. What do you do in this particular case? There are no specific guidelines on how to treat Stenotrophomonas multifida in CF patients, but there have been some guidance done lately by Tama and colleagues. These are some agents that you can use, as well as the doses for Stenotrophomonas multifida in CF patients. Usually for Stenotrophomonas multifida, we're looking at using 2 agents that are active against Stenotrophomonas multifida. Next, we're going to talk about Achromobacter xylozoxidans. Achromobacter xylozoxidans is a non-lactose fermenting gram-negative rod. There are currently no guidelines on how to treat. I now want to bring in a new patient, AE. AE is a 35-year-old male who is not eligible for modulator therapy. He is chronically colonized with Achromobacter xylozoxidans. He has had 2 hospitalizations in the last year due to Achromobacter xylozoxidans. Review of current sputum continues to show Achromobacter xylozoxidans. AE has no known drug allergies. This brings us to clinical quandary number 6, how to treat multi-drug resistant Achromobacter xylozoxidans. So if you have this particular isolate of Achromobacter that is pan-resistant, what do you recommend in this particular case? I now want to talk about this publication from Gainey and colleagues. The last slide showed an Achromobacter xylozoxidans that was resistant to all agents. So Gainey and colleagues used meropenem vaborbactam plus cefiderocol and phage therapy. When all 3 agents were administered concomitantly, the FEV1 improved from 33 to 56% on day 6 of therapy and up to 60% on day 12 of therapy. The patient went on to complete 14 days of therapy, and the regimen was reported to be well tolerated by the patient. This particular slide shows how the patient was started on cefiderocol with meropenem-vaborbactam, and then phage therapy started at the end of the antimicrobial therapy. And on the right, it shows how cefiderocol, along with meropenem-vaborbactam, along with phage therapy, were all started at the same time. And you can see when they used all these three together, the FEV1 went from 33% to 56% on day 6, and then up to 60% on day 12. This slide provides information with antimicrobial agents with the most activity in vitro against Achromobacter xyloxoxidans. Next, we'll talk about B. cepacia. B. cepacia is associated with increased mortality and morbidity, and currently there are no guidelines on how to treat. These are the most active antimicrobials in vitro to B. cepacia. This brings us to Mycobacterium abscessus, using at least 2 IV agents for the initiation phase and 1 oral, and for the continuation phase, using 2 orals and 1 inhaled agent. And when treating MAC, using azithromycin, rifampin, and ethambutol, treating both of these for 17 months. Inhaled amikacin is going to work by inhibiting the bacteria's ability to make proteins. Utilization in cystic fibrosis is not currently reported in the registry. It is FDA approved for patients 18 years or greater with Mycobacterium avium who are not responding to guideline-directed therapy. It is not yet approved for chronic Pseudomonas in CF patients. It is dosed at 590 milligrams once daily via nebulization for 28 days continuously for 6 months. Adverse effects are hemoptysis, cough, and sore throat, to name a few. Talked about a lot of antibiotics today, using at least 2 agents for Pseudomonas, even using more agents for things like B. cepacia potentially. And when you think about antimicrobial therapy, it can cause gut dysbiosis. And we do know that gut dysbiosis can affect lung function, and lung function does go hand in hand with survival. MVW does have a probiotic mini for kids and also one for adults that can be taken to improve that gut dysbiosis. Cystic fibrosis is a very complex genetic disorder. A multidisciplinary approach can improve patient care. Isolation of MRSA can have a negative effect on CF patients, and CF patients may benefit from prolonged infusions of beta-lactams. An individualized approach can improve CF care. Thank you.